a good one to do today because we do see quite a bit of our prenatals that have gestational diabetes. And I know a lot of us already know a lot of this information, but I thought it would be like a good review. So I hope you guys will participate and it'll make it a little bit more interesting, okay? So can I get someone from Region 1 to read the WIC mission statement and the public health, please?
Good morning. The mission of the WIC program is to safeguard the health of low-income women, infants, and children up to age 5 who are nutrition risks by providing nutritious foods to supplement diets, information on healthy eating, and referrals to health care. Public health mission: inform, prevent, and protect.
Thank you. Okay, so my learning objective for today is after the presentation, you all will be able to explain the risk of poorly controlled diabetes during pregnancy, identify key changes for women with gestational diabetes, describe the role of healthy eating, and describe the role of safe exercise. And just a little overview, we're going to talk a little bit about what gestational diabetes is, the risk factors, and the importance of controlling blood sugar. We're going to review some basic nutrition principles to manage it, and also review the importance of prenatal exercises. Well, let me go back. So can I get someone from Region 3 to tell me what is gestational diabetes? I kind of cheated just now, I already flicked my slide, but can anyone tell me what gestational diabetes is? Or what is gestational diabetes?
Hey, this is Emma from Henry. Gestational diabetes is diabetes that develops during pregnancy.
Okay. Thank you. So you're right, it's diabetes that develops during pregnancy, but most of the time it goes away after delivery. It usually develops after the 6 months of pregnancy, and it's diagnosed at the 24 to 28 weeks gestation, and that's usually done with the glucose tolerance test. Gestational diabetes usually cannot be prevented. It's just something that happens to some people. And according to the CDC, the prevalence is as high as 9.2%. And with careful monitoring of blood glucose, diet, and exercise, a prenatal woman with gestational diabetes can have a healthy pregnancy and positive birth outcome. There's really no known cause for it, but it is believed that because of the high hormone that's produced because the baby is growing in the second trimester, the hormones kind of blocks the woman's ability to use the insulin in her body, and this causes insulin resistance. So sometimes they may need as much as 3 times more insulin to, deal with the glucose that's in their bodies. So some risk factors are, if you're over the age of 25, if you have a family history of diabetes, overweight or obese at conception, and if a woman had previous history of gestational diabetes or gave birth to a 9-pound baby or more, and then the high-risk ethnic groups are your Hispanic American, African American, American Indians, and Asian Americans. Most of the times there are no symptoms, and then, like I said, after delivery, the insulin returns to normal. So some treatments are, regular monitoring of your blood sugar is important, and usually it's recommended in the morning before breakfast, and this is considered fasting, and then 1 to 2 hours after each meal. When they are diagnosed, they really need to make some dietary changes so that way they can better control their blood glucose. And also exercise is important, and it's for everybody, including women who have gestational diabetes or don't have it, and everyone else. And also they want to control their weight gain. They don't want to gain too much weight. And I didn't put that slide on here, but we all know what the weight gain is for each category. So we just want to, when we counseling our clients, kind of encourage them to stay within the recommended weight gain for their pre-pregnancy weight. In some instances, diet and exercise is enough to normalize the blood sugar, but in certain instances, if it's too high, they may need medication or insulin. Okay, so now we're going to talk about some risks for the baby. And the first one is macrosomia. Can anybody tell me what that is and how that happens or why it happens? How about region 1?
Hey, Shakila, it's Lindsay.
Hi, Lindsay.
Well, basically, the extra sugar, glucose in the bloodstream will deposit as fat on the baby, and the baby will end up, weighing more than it should or large for gestational age.
Okay, and that's correct. Because of the increased blood sugar for the mom, it crosses the placenta, and that makes the baby gain a lot of weight because he or she's getting a lot of extra energy. And a big baby can also cause complications at delivery, and the main one they talked about is damage to the shoulder. The baby can get stuck, and he can have a broken shoulder. So that's why it's important to counsel our parents on proper diet and exercise, so that way they don't end up with a large baby. And one of the other risk factors for the baby is hypoglycemia. Can someone from region 2 tell me why hypoglycemia would occur in the baby after delivery? No. Terry, you want to take a shot at it?
It says here the blood sugar's too low. Is that what you mean?
Yeah, but do you know why it's too low?
No.
Okay, because of all the extra sugar that the baby's getting while in the mom, the baby ends up producing more insulin. So when after delivery, they have all that excess insulin but not enough sugar, and so the baby's blood sugar tends to drop. So a lot of times they'll give them an early feeding of formula or some glucose to bring that back up to normal, and it usually disappears within 1 to 2 days. Another risk for the baby is they can get jaundice, and in some instances respiratory distress, and it said here birth defects, but when I read some more article, it says birth defects is not likely with the gestational diabetes because the baby is already formed at this stage. It's usually in type 1 and type 2 diabetes. If the blood sugar, if the diabetes is poorly controlled, there are risks for a lot of birth defects, okay? And then the babies are at increased risk for obesity and type 2 diabetes later on in life. And does anybody know what complications for the mom? What are some complications for the mother? Region 3. Anybody want to take a shot at it?
Sometimes the delivery can be difficult, or high blood pressure. Difficult delivery, or high blood pressure.
Okay. Thank you. So some complications are like, and I didn't get your name, but it's high blood pressure. Tina? Urinary tract infections, because bacteria love sugar. So if there's a lot of sugar in there, they're going to have a great time. So a lot of times you're increased risk for urinary tract infections, increased risk for C-section births, preeclampsia. We see a lot of this in a lot of our clients. And of course, preeclampsia, you have the high blood pressure, your protein in your urine, and swelling in your face, hands, and feet. And I tried pronouncing this word, so I'll go again. Polyhydramnios, and what that is just excessive accumulation of the amniotic fluid, which can cause early delivery, and it only occurs in about 1% of pregnancies. Okay, so the medical nutrition therapy is you always want to make sure you're doing an individualized balanced meal plan. There's no one size fit all for anybody with diabetes. Or any other plan that is. And then, of course, you want to make sure both mom and baby are getting adequate nutrition. You want to encourage vitamin and mineral supplementation is needed. Like I said before, appropriate weight gain. They always want to make sure they maintain their normal blood sugar levels. And, of course, we always promote and support breastfeeding. And then you want to encourage regular physical activity. So what are some things that you guys are already telling your clients when they come in with gestational diabetes? What are some suggestions you're already giving them? And anybody can answer.
Hi, Shakila.
Hi.
For them to eat really frequently and to focus on complex carbs instead of simple refined carbs.
Thanks, Dahlia. That's correct. So you always want to do 3 meals and encourage 3 meals and 3 snacks as much as possible. I know when I was in the hospital doing my clinical, the dietitian over there, she had said 3 meals and 3 snacks are not always doable because people have work, lives and they work, and that's not realistic. But when I did my diabetes rotation, they really pushed the 3 meals and 3 snacks. So I kind of, when I do my counseling, I like to encourage, the 3 meals and 3 snacks, or eat every 2 to 3 hours. And then you always want to avoid no more than 10 hours between bedtime snack and breakfast. And can anyone tell me why? Ryan, do you want to give it a shot?
Oh, no, you repeat that. I had to go let somebody in the door. What'd you say?
Do you know why they say to avoid no more than 10 hours between bedtime snack and breakfast for the
Yeah, because sometimes when you go too long, I can't think. I was about to say the hormone name, but the hormone that can increase, you can actually have a high blood sugar in the morning instead of a low blood sugar because the liver actually starts releasing more. It's what do you remember the name of the hormone? I can't remember that hormone name, but it actually causes a reverse effect. Instead of having a low blood sugar, you actually have a high blood sugar in the morning time.
Yeah, and it's mainly because the liver spits out more glucose overnight.
Yeah,
if
there
you
was
go
a
too
there was
long.
there was a hormone, and I can't think of the name of it right now. Anyways, it's because of that hormone is what causes the liver to spew more sugar. I'll think of it in a minute.
I think it's resistant. I literally think it sounds like resistant. I think it's that.
that may have been it. My mind went blank. I can't remember it.
Okay.
Thank you. And of course, you wanna encourage them to synchronize their meals and snacks with their medicine or their insulin, and encourage them to keep a record of their foods and blood sugar. They really want to keep their carbs consistent, and it's not a no carb diet. It's a consistent carb diet is what they need to be on. And of course, they need adequate protein and healthy fats and lots of vegetables. And I always like to tell them this, they can eat 3 times as much vegetables to equal 1 gram of carb, whereas, if you're just eating your carb alone, sometimes that doesn't fill you up as much. Okay, and then some nutrition guidelines is you really want to you want to tell them to spread their carbohydrates throughout the day with their 3 meals and snacks. Always want to watch their portion sizes. And it's really a good idea, especially if this is their first time. You want to encourage them to start weighing and measuring their foods. They don't have to do it all the time, but really at the beginning, just to get an idea of what a serving size is. And then, later on, they might want to redo it just to make sure that they stay in, because after a while, our portion kind of get bigger and bigger, and we lose track of it. So encouraging them to weigh and measure their food is really a good practice for them. And when I did my diabetes rotation, I thought this was interesting. They recommended no fruit juice for their gestational diabetes patients because, in the morning, the hormones are higher, and it already increases a woman's blood sugar. So they were saying if they drink fruit juice in the morning or even ate fruits, some women can handle it because it'll spike their blood sugar levels even higher. So, and sometimes people don't understand what's a little or a serving size, so they thought it was best to tell them no fruit juice at all. And if they ate fruits, they want to eat it later in the day and not at breakfast. And again, we want to encourage them to read their food labels because they'll be amazed what a serving size is and how many servings of carb they're getting in, the foods that they're buying. They also want to limit the instant cereal, rice, noodles, potatoes, because all those spike your blood sugars even faster. Limit sweetened beverages, and that is including your 100% juice. And then we can always refer them to the myplate.gov. And I found this really neat MyPlate for gestational diabetes. And I think this is so helpful because sometimes they don't understand what you're telling them. But like if you have a visual to give them and kind of explain it, it really breaks it down. So I really like this. You can just Google it and save it on your desktop because that's what I do. And I just print it out and give it to them and explain it. So that way they have something to go on instead of just, telling them eat 3 meals and 2 snacks, what your portion size is, don't eat this, don't eat that. So I thought this was really helpful. Did you guys look at this one before? Did you have it before? Is this the first time you've seen it? No, yes, maybe?
First time I saw it.
It's the first
What do
time
you
I've
think
seen
about
it.
it?
Looks pretty good.
Okay. I mean, if you want it, I can always attach it and email it to you guys if you want it. And then, of course, this is the second part to it. And of course, the most important thing, again, one of the other important thing is exercising during pregnancy, and the recommendation is 30 minutes of moderate intensity, most days of the week, if not all days. You want to encourage them to include aerobic as well as strength training, and then they always want to check with their OBGYN first before they engage in any type of physical activities. And then, we all know this, your exercise can lower your blood sugar levels after meals. It reduces the chance for needing insulin or medication or needing more, and it also prevents excessive weight gain. Does anybody have any questions so far? I know I talk really fast, I'm sorry. No questions? I guess not. Okay, so just to summarize, again, food plays a major role in controlling blood sugar. We need to provide a customized meal plan and weight gain goal for all our clients. There's no one size fit all. Pregnancy is a good time to make positive changes, so you can always enforce that or encourage that, and at least 30 minutes physical activity daily. Include aerobic and strength training, and exercise benefits both the mom and the baby beyond lowering blood sugar levels. And it's really important for all women with gestational diabetes to see a registered dietitian. So I only did one little case scenario, and this is something that I experienced, but I want you guys to take a shot at it, and then we'll just go by each region and get everybody's input on it because everybody does things differently. So can I get somebody from Region 1 to read it for me, please?
A prenatal client in your clinic for a HR follow-up visit for overweight. You went into the waiting room to call the client back into your office. The client glares at you and looks very angry. How would you approach this client and start your visit with her? Do you want me to answer that first one or read all of them?
Well, you can read all of them, and then we'll kind of just go over it together, and see what are some suggestions you guys have for how you would handle this situation.
Okay, again, that first question was how would you approach this client and start your visit with her? Let's say you asked her if everything was okay, and she said, I had a visit with my doctor 2 days ago, and she told me that I have gestational diabetes and that I cannot eat any carbs. No bread, no rice, no potatoes, so what am I supposed to eat? I am hungry. How would you counsel this client? What approach would you use, and what referrals would you make?
So Geneva, did you want to answer any of those questions?
I can take the first one as far as how would I start the visit with her. I would just make her feel comfortable and try to figure out, what's going on. Like give her room to voice what's actually going on with her. Since she's coming in bombarded, I wouldn't want to overwhelm her with how I feel. I would start it off by getting her to let me know what's going on with her. And then I would give her feedback off of how she explains what's going on with me.
Okay, good. Does anybody from Region 2 want to answer the second question? No, Victoria?
Let's see.
Dahlia, you want to give it a go?
Oh, okay.
Since Victoria doesn't want to speak?
I would let her know that the recommended diet for people with gestational diabetes isn't a no-carb diet. It's just a controlled carb diet. I tell her that we have dietitians on staff, because I think if she needs for someone to sit down with her and do an individualized meal plan, that's definitely who she's going to need to speak with. But I would also ask her if her doctor's office didn't already say something about making an appointment for her with an RD, and if not, then I would go ahead and make those referrals for her.
Okay, so you kind of answered the last one also. Does anybody have anything different, anything else they wanted to add on how they would approach the client and how you would counsel?
Hey, Shakila, it's Lindsay.
Hi, Lindsay.
I think it's really important to help her understand what she can have. I know, especially when I was at the diabetes center, a lot of the patients are concerned that they can't have this, they can't have that. I can only have 45 grams of carbs. What am I going to do? That's not very much. But if you sit down with them and help them build the plate to see what they can have on there and discuss with them, you know, not all of our food are carbs. You know, there are other foods. There are non-starchy vegetables. There are some good proteins that you can eat. And help them to understand what they can have on the plate. You know, if they're limited with that carb, what else can they add to the plate to make the plate full? So I think it is really important not to focus on what they can't have, you know, as long as they understand past that point, but focusing on what you can have, especially, you know, in the morning times with the diabetics that, you know, have to limit their carbs a lot more than some others. And as far as like individualizing their plan, I think it's really important to encourage them to keep that log and log their blood sugar, because some carbohydrates are going to affect some people differently than others. So for that person, maybe potatoes aren't the best idea, but what can they have in place of that? So I think that's really important.
Okay. And what I wanted you guys to get, this actually happened to me in Fayette, and I swear if I hadn't asked her, you know, what was going on and, you know, really talked to her before and just went on and told her something else she couldn't have, I swear she would have knocked me down, because she was really, really mad. And can you imagine being pregnant and hungry, and then somebody tells you cannot have one more thing? So you always like, I think Geneva said, you always want to, you know, give them that room to tell you what's going on. You want to, you know, set that groundwork. You don't want to just get into a counseling session and tell her anything else that's negative. And another thing that I really wanted you guys to get out of this is a lot of people out there are getting a lot of misinformation and a lot of inaccurate information, especially where diabetes is concerned. And they hear all kinds of stuff. So it's our job to kind of help them navigate through all those murky waters and see it's not as bad as some people make it out to be. Like if they really eat healthy and exercise and, you know, have a good meal plan, they can have a healthy pregnancy, and they don't have to go through all those risks that we just looked at before. So it's really our job to kind of help them figure it out, because they do get a lot of misinformation out there. And it's not a no-carb diet, it's a consistent carb diet. And you'll hear that a lot of times. People will tell people with diabetes, oh, you can't have that, you can't have that. And that's like the worst thing you can tell somebody, you know, you can't eat that. So I think it's all about educating them and being there for them and providing the resources we have. And like I said, I really like that My Plate for gestational diabetes. It really explains it and breaks it down for them. Does anybody else have anything they wanted to share? Any other
I have a
dietitians?
question.
Uh-huh.
It says on the plate that for gestational diabetes, it's not recommended that they have milk or yogurt for breakfast. Why?
And I thought that was different, because when I did my diabetes, they didn't do it that way. So that's the only thing that I found different on this. It's really all about controlling their carbs, and they can have milk. I think the thing that they focused on a lot was the fruit, no fruit at breakfast time, but the other carbs they can have. So you can always talk to them. Sometimes people are not milk or dairy drinkers in the morning, just as long as they get in their consistent carb. And they're not doing too little or too much at any one meal, because, you know, if you do too little, blood sugar will drop. If you do too much, it'll spike it up. So it's really about being consistent. So that's something that you can, you know, again, individualize, see what it is, you know, fits their lifestyle and their eating pattern. So,
okay, thank you.
Did that answer your question, though?
It did. I know when I saw it, I was like, oh, I didn't realize that because I know a lot of diabetics. I mean, well, I don't know many gestational diabetics patients, but I know a lot of people that have milk and yogurt for breakfast. I wasn't aware that they couldn't have it.
Yeah, I was kind of surprised with that one too, but they can. Any other question?
I was gonna, Shakila, Carly, you was right. That is called resisting. That I think of it, but what it was called is what I was trying to think. It's called the dawn phenomenon. You know, when they go 10 hours, and then you have it's rebound hyperglycemia, and you were saying something about not the fruits in the morning, and I remember when we did our diabetes rotation that you actually want to have a gestational diabetes want to have less carbohydrates in the morning and kind of increase as the day goes.
And again,
so
that's oh, sorry.
Yeah.
Go ahead.
No, I mean that's all I was gonna say, and that's kind of why, because the blood sugar levels are already in a gestational diabetes a little higher in the morning, and so that's why their carbohydrates in the morning. They still need some, it's just a lower amount than somebody that would just regular diabetes that doesn't have gestational diabetes. And that, so.
Thanks.
And Ryan,
anything else?
Just to piggyback off of that, like I think it's really, I mean, it can't be stressed enough that we encourage them to check their blood sugar, because I know I've talked to gestational diabetics who, they just really needed to resort to some insulin with their doctor and talk to their doctor because, sometimes they can't get those numbers down no matter how little carbohydrate they eat. So it is really important to encourage them to make sure that they're making those appointments with their doctor, that they're checking that blood sugar, that they're connecting with the resources that their doctor or endocrinologist may have to get themselves a glucose monitor.
Thanks, Lindsay. Anything else? Anybody?
Hey, it's Carly. Yeah, I was just looking at the NIH website, and it was saying that the resistance is higher during pregnancy for even normal women. And then, of course, definitely increased in GDM. A couple things I wanted to add to this was there's the diabetes food guides that they had at Wellstar. They're from Novo Nordisk, which is one of the insulin companies, and we can get those free because we're healthcare professionals. And so that's something that we may want to think about stocking the clinics with in case they haven't seen a dietitian at the hospital or the fetal medical centers. So to give them something to say, here's a food guide, here are your portions for these foods. You can still have foods, you just have to watch your portions, to give them some information. The other thing is I've been recommending for some moms who have had GDM and just found out and they say, I don't know what to cook, I don't know how to eat, I don't understand this. Enrolling them in the cooking classes and the shopping tour. I had a mom in Griffin last week that was all about the cooking class and shopping tour because she didn't even know where to start. So that's another good resource that we have here in WIC. I think that's it. Thanks.
Carly. Anybody else?
Hey, Gwen wants to say something. Hang on.
I just want to remind everyone that using references is great. I mean, that's a good point, Carly, about what Wellstar had. But follow the chain of command. It needs to come through your if you're going to use something and order something, it needs to come through your regional manager. They'll give it to me, or you can give it directly to me, and then I have to get it approved through the state. So we can't be ordering things out there and to use in your clinic. If that's something we need, I'm all about getting it. Just remember to follow the chain of command. That's all.
Anything else? No?
Hey, Shakila.
Oh, sorry.
This is kind of on a related but separate note. There's a very interesting documentary out there by Novo Nordisk. You can actually search it on YouTube, and it's about the development of insulin. And I think for any healthcare professional or nutrition professional, it's really eye-opening. It's informative, and it's also good to really know the background of diabetes in general and just how severe the condition is and where that kind of background came from. So if anybody's interested to search that, it's very interesting, by Novo Nordisk.
Anything else? Carly? Would you kindly read my good to great quote, Carly, please?
Yes, ma'am. The moment that you feel the need to tightly manage someone, you've made a hiring mistake. The best people don't need to be managed. Guided, taught, led, yes, but not tightly managed. By James C. Collins.
Thank you. Does anybody have anything else before we go? I know we have extra time.
I just want to add, Shakila, that I sent the link to the evaluation. So once y'all are done, to please go back and fill out the survey.
Okay. Well, thanks everyone. I hope this was helpful. And, it's something that we can use every day because we do see a lot of clients with gestational diabetes. Thank you for your time and attention. Appreciate it. Have a great rest of the day.
Thank you, Shakila.
Thanks, Shakila. Good job.
Thank you.
Thank you.
Thank you, Shakila. Great job.
Thanks, Carly.
Those were cute slides.
Didn't you like my pregnant lady? Don't you wish we all could look that